I want to introduce Brandon to you. Brandon is an attending at the University of Kansas, at the medical center there. He did his residency there, ended up doing a fellowship out at HSS with the likings of Todd Albert and Shiraz Qureshi and Hanjo Kim, and a really great group of guys. I've known Brandon for many years, early on through the ISSG and some of the interactions we had there with his senior partner, Doug Burton, who's an amazing guy. And then a little post-fellowship, Brandon and his partner, Josh Bunch, came out to hang out with us here at SDSF for a while and see more lateral work. And since then, he's caught on to a few things. One is he's become lateral surgeon, and some of the x-rays he sends me are phenomenal. And then the other thing that he's found a significant interest in is metabolic bone disease. And I thought this would be an amazing time for him to share with us what he's learned. And as surgeons, what our interaction should be with this really important part of our practice. So Brandon's an awesome guy. He's married to Lindsay, who's amazing. They both live in Kansas now. And anyways, he's a great friend, and I really look forward to hearing from you this morning, Brandon.
Awesome. Thanks, Greg. Appreciate everyone's time this morning. I had this opportunity last year to do the same similar talk and just thought it was great. Got a couple of emails afterwards, and the feedback was pretty good. I tweaked a few things this year, try to update a little information, but where the source of this came from was, as I started early in my practice, I'm always reaching out to people I know and trust, like Greg and Bobby Slack out there and others around the country. And you're always asking questions about things that maybe are okay defined or somewhat defined in the literature, but then, your personal experience might sway you a different way, or maybe you're planning for a big case and you have all these thoughts in your head. And so I started just reading about, metabolic bone disease. And in our part of the country, we have a decent segment of people that don't have the greatest health. And so we see a decent amount of even fragility fractures that just come right into our emergency department that, they're not elective spine surgery cases. But I still just found this sort of interest in better understanding that world and speaking the language. So in reading some of that, I just even would come to some conferences, very well respected spine conferences, and I would hear sort of information that was lacking, or maybe misinformation or confusing information. And so I just thought this would be a helpful thing to review for the surgeon. So I know I only have about 30 minutes, so I'm going to try to, and I got on a little late, so I'm going to try to go quickly. There's a lot of content, but I know there's a lot of people on here in Zoom. It's still not the best thing in the world, but here we are connecting halfway across the country. And so if you see something or hear something, please speak up and just cut me off. I'd rather just talk openly about what I have seen and read versus just doing the slide game the whole time. But as such, here we go. So these are my disclosures. There's none really relevant to this presentation that I don't have any conflicts with bone disease companies or medication companies, and I'll put a couple brand names in there. But so the biggest thing is this is all around us. The World Health Organization and the international entities that study metabolic bone disease, they basically say, even back in 2007, so this is dated information, that there's 200 people around the world that have affected bone disease. And we're seriously seeing that around us all the time. And we know that it's growing because our population's growing. And right in 2010, using census data, he showed that there's about 10 million people in the US that have osteoporosis, which is, the most severe component of this, versus even 4 times as many people just had low bone mass. People have looked at this, and spine literature in particular. I put this paper up here because it's cited quite often. And I think it's kind of interesting that this Wagner paper gets so much attention. I think it's probably because it shows up in Spine. It's a 2016 paper. They looked at 143 patients, but really only 29 of them had a DEXA scan, and that's still considered gold standard. And we'll get to that in a minute. But they looked at CT measured Hounsfield units, and they created a threshold that they were defining essentially in their paper to look at how many of these 143 patients had low bone mineral density. And you can see here, 49% of all their patients over 50 years had it. So just imagine that for a minute. These people are coming into our spine clinics, and most of them are over 50, and about half are going to have abnormal bone mineral density. And it's interesting. We did a paper similar to this when I was in fellowship, maybe a little bit more objective measurements. So 296 consecutive patients, we used QCT, and I'll talk about that here in a minute if you don't know what that is. And none of these patients had a history of fragility fractures, so no clinical diagnosis of osteoporosis. You can see here 15% had osteoporosis by QCT diagnostic criteria. 43.6% had osteopenia. And so that's total of the same cohort over 50 years of age. 67% of them had some sort of abnormal bone density. So it's clearly a problem, and it's around us all the time, and it's going to affect our practices and our surgeries that we perform. But better understanding, to kind of put it out there clearly, osteoporosis is, people talk about it as, oh, you got weak bones, et cetera. But it's really a very specific diagnosis. And this is the actual definition: disease of living bone tissue resulting in generalized skeletal fragility, in which both the density and quality are sufficiently weak that fractures can occur with minimal trauma. And that's kind of the key there, is that it's all about fractures, right? So osteoporosis, the diagnosis essentially says, what is your risk to have a fracture? And so then really it comes down to, well, there's density and there's quality. And a lot of people don't really get this or understand this, or maybe it's not a big focus for them, but these are two completely different things, and they work hand in hand to create the strength of your bone and prevent fractures. So bone density is based on the amount of minerals, particularly calcium and phosphorus, in a given volume of bone. So we all call it bone mineral density or bone mass. And the density is actually what we use all the time to make diagnoses. Bone quality, though, is a composition and structure. It's how it's formed or put together. It contributes to overall bone strength, but it's independent of necessarily the density. So you can have low density bone with high, a well-formed structure. And so there's things like bone turnover, microarchitecture changes, mineralization changes, or microtrauma or microdamage that can change the bone quality. We really don't know how to measure it too well. I mean, we have a couple methods, and I'll talk about one briefly, but we don't really use it routinely. And so we're not always talking about bone quality when we talk about our measurements or our density measurements that we're always referencing. But I think in the future, you're going to see that this becomes more, as our imaging modalities become easier to use or more readily available, this will be more impactful for our careers. So getting really into the thick of where this talk started is better understanding, the measurement techniques, the different imaging modalities, and getting really a lot of detail out there so that surgeons like yourselves or anyone on this call could understand or really translate what they read and see. So DEXA is the gold standard. We've all seen this report on the right here. It stands for dual energy X-ray absorptiometry. It's a two-dimensional image. So it was actually developed back in the 60s, and it's still considered widely the gold standard for screening. We can measure it at a lot of different locations in the body, and there's different sensitivities and there's different accuracies for those different areas. It does actually quantify bone mineral density. It's usually reported as a T-score. However, they also report a Z-score, and you can see that on that table there on the far right. The advantages are it's low radiation, it's easy to repeat. You can use it to trend people's bone density over time. The disadvantages are it's less specific for cortical or trabecular bone, and degenerative changes specifically in the spine are going to overestimate that density. And many people disregard the spine measurement altogether in patients who are coming in with spine conditions. CT. So this one in the next slide, and I'll show you quickly, and then I'll come back. So this is QCT, but CT is one that we talk about a lot. A lot of people use it. I use it myself. It's an opportunistic screening method. It's actually just a measurement of bone attenuation. So if you think about it from a digital standpoint, the software we use to measure CAT scans can give you a measurement of the density of the pixels. So that's what a bone attenuation is. It's not actually measuring the bone density. So it's showing you how many pixels are in this circle and how dense are they, but it's not measuring the actual bone density like the other methods that quantify it. There are correlations that have been shown to look at Hounsfield units, which is the pixel measurement versus bone mineral density in DEXA, and it's quick and easy. So we always, it's common to get a CT scan preoperatively. You can you can see this picture on the right. You draw these little circles, and all of a sudden you have numbers, and you can use those numbers to make decisions. There's no additional cost if you use it from an opportunistic standpoint, but it does have high radiation. If you're ordering a CAT scan just to get the Hounsfield units, you are incurring costs, so that's a consideration. It does have conflicting thresholds, and I'll get to that here in a second. And so it's very confusing to kind of think through the numbers. Which number should I use? And then people that know and use quantitative CT, which I'll talk about next, the numbers are very close to each other, so it becomes very confusing. So QCTs become more widely accepted as a standard practice or a standard measurement. It actually uses a reference. So the original versions of this, you would actually put a reference frame underneath a patient during the scan that had different densities of water and other fluids. And they could use those fluids to match or convert the density of the bone that they saw as an attenuation measurement. So you can see it here on the right. There's a software that they use. It's volumetric. So it actually looks at it in the axial and the coronal view and uses that volume space to give you a number. That number is actually a bone mineral density measured in milligrams of hydroxyapatite per centimeters cubed. It can measure cortical or trabecular bone independently and will give you very sensitive results to both of those. It's more accurate in degenerative conditions. The problem is it's high radiation, it's expensive, and we don't widely use this because we don't have, not every place has the software. Places that do, they use it all the time because it's very simple, and you can actually use a pre-op CT and use the software that doesn't use a phantom. And next thing you know, you've got an accurate bone mineral density. It's so widely accepted that the ACR has actually given recommendations. You can see them here as the numbers that would go along with the different diagnoses. So they can use this for diagnoses. So who should we screen? People over 65 or people over 70, males over 70 is the WHO recommendations. There's also a lot of risk factors that I think we all start to consider. Different medications now we see, different medical conditions that can affect bone metabolism, smoking, alcoholism, history of a previous fracture. And now it's very common that as we as spine surgeons are looking at this and knowing the complications associated, we plan to screen a lot of people that go for elective spine surgery. So how do we do that? We obtain a DEXA scan. We can either get that through primary care or we order it ourselves. And then many people, myself included, will use this FRAX score. And the FRAX score is a widely accepted and well-published, essentially a scoring system or a tool you can get online, and you just punch in a bunch of numbers. And it's interesting, you should notice that they use the femoral neck bone mineral density. I think this is a big point to take home, that the lumbar spine bone mineral density or DEXA scores, however you want to look at it, they have QCT even on here. That's not what they're asking for. They really are most interested in femoral neck because it's the most widely studied, highest sensitivity, and most accurate. And so as you go through, if you're going to use a FRAX score, you're going to see that they're going to ask you for these other factors, and this could give you a fracture risk assessment tool. Now, I don't take that number and directly translate it to how I'm going to do a spine surgery, but it also gives me just a baseline for that patient. It's something nice to document, and it can also direct your future treatment for that same patient. So quantitative QCT, a few more details here. It measures the volumetric levels or volumetric portion of the vertebral body. You define these circles and these boxes, and then it creates that volumetric measurement. The recommendation is to do it at L1 and L2, and then average the two. Use the ACR criterion, you can make a diagnosis. And when you're looking at CT Hounsfield units, there's a lot of discrepancy in terms of what thresholds to use. There's different correlations with DEXA, but some don't correlate well. And so it's interesting. This is a sort of a summary slide I created that sort of put this all in a framework for my own brain. DEXA, we all know the numbers. It's very easily translated. You can talk about it to another clinician very easily. And we know that minus 2.5, two deviations below the threshold of a normal age-adjusted normal person would be osteoporosis. The QCT, you see those criteria there. Again, I showed those before. That's defined by the ACR. But then on the right, this is the Hounsfield unit data. It's all over the board. And I didn't even put all the references because this isn't even all of them. But What's interesting, and I'll bring your attention to, the one that's talked about the most, even when you go to a meeting, is this 110 number. And it came from a study that found it to be very, very, very specific for creating or correlating with low bone mineral density or osteoporosis. And so what kind of stinks in the whole thing is that you're looking at the numbers for the quantitative QCT, and people talk about those pretty often in meetings, and then the number for the Hounsfield unit QCT, or Hounsfield unit measured also off of a CT. So someone will say, well, we measured the CT scan and the number was this, and we decided we were going to treat their bone health. And that's the part that I think gets me a little bit riled up sometimes, and maybe I should just let it be. But I think it's important to understand, what was measured. Was it the Hounsfield units, which again is pixels, or was it actually a conversion to a bone mineral density? Because you'll probably use them and interpret them differently. When I looked at evidence that supports these, the World Health Organization obviously backs up the DEXA one, and that's still the gold standard. ACR adopted and backs up QCT. And then you've got all these papers that are kind of all over the board. They all have different thresholds they define. How their methodology of getting there is sometimes confusing. So just be careful when you're interpreting Hounsfield units. I still believe these are all useful tools. So I'm not saying don't use Hounsfield units. I'm just saying understand what it actually represents, and then know how to use that information. So DEXA is still widely accepted and used. It's probably the one that most people will be able to order and trend over time. So what about that quality I talked about earlier? I just said that density is what we use to measure, but quality might be more important. I think we're going to see a lot more of this in the future. I just bring this paper up. It's out of New York. My fellowship director published it, but I helped in some of the collection during the time I was there. And we use this thing called a high resolution peripheral QCT. It's this very unique and interesting machine that's probably extremely expensive. And they would shoot these crazy looking x-rays of the distal radius, and then they could measure the microarchitecture. They found that actually the people with microarchitecture differences were the ones that had complications after spine surgery and didn't actually correlate with their density on a DEXA scan or a QCT. So again, I think this will be a hot topic probably as we get better technologies or easier access to imaging modalities that can show this kind of stuff. We're going to be talking a lot more about bone quality in the future, probably not as much about density. So for the clinician taking care of a patient who has metabolic bone disease, there's a lot of other information, and I'll try to dig into this in the next 5 minutes or so, and maybe leave a few minutes for questions. We should order labs. I think if you're going to manage this yourself, you need to know what labs to order. The simple ones here are vitamin D, calcium. You can get a CMP that gets a lot of these, calcium phosphate, PTH. I actually order those on top. There's a reflex order in our system where if they have a abnormal PTH, you can get a whole thyroid panel. So thyroid studies and the PTH kind of go hand in hand. Some people, creatinine and alkaline phosphatase, can also be used as important markers. Alkaline phosphatase in particular, markers of bone turnover. And so you need to be suspicious when this patient comes in your office if they have an abnormal bone mineral density. Again, I showed you maybe 50 to 67% of these people are going to have something, and you need to understand why. And if it's age-related, it's generalized aging. Maybe you or the surgeon or the primary care can manage it. But if it's other reasons or other metabolic problems, you might need an endocrinologist to help you out. There's some secondary causes of osteoporosis that go hand in hand with other endocrinopathies, and I think they're important to be treated appropriately. And you probably don't want to manage that yourself in some instances. But then really you need to know, what do they need? Is this a degenerative case that's one level? You're certainly going to handle that differently than a deformity or maybe a cervical procedure. How urgent is it? Can you wait a little while? Can you get them ready? And then what are your treatment options? And so there's a lot of papers that have popped up through the years. And the bottom left one I'll talk about in a little bit more detail because it's the most recent that have given you suggestions, told you what to do in the spine patient. How do I, what evidence is out there to support the different things we try? When I kind of go through some of the categories, so there's medications and then there's surgical methods. I think for the purposes of this talk, I'll steer more toward the medical side of things, as I know that many lectures, you could have an entire hour lecture on some of the surgical techniques that I'll just touch on, but bisphosphonates are the first and oldest medicine we use for any treatment of osteopenia, osteoporosis. It's an anti-resorptive medicine, so it's trying to stop your body from breaking your bones down. There's been several studies along the way in spine patients in particular, and they show differing results. Sometimes they show increased fusion rates, sometimes they show decreased fusion rates, sometimes they show no differences. So it's probably not the whole picture. It's probably not the whole answer or the only thing that we need to use to try to improve complication rates or the successful outcomes for these patients. Even this patient, the paper here at the bottom, the 2014, showed pedicle screw loosening was actually higher in the patients that had a bisphosphonate medication, which is sort of concerning, I guess, for us to use this as a method to try to prevent problems with our spine surgeries. So I don't think these are the medicines that we now commonly talk about and use, especially when we go through big elective spine surgeries, even smaller ones, but in these particular patients. And so then we get to the PTH analogs, and these are the ones that I think everybody seems to know about and start using a lot more in the last several years. The two here, a brand name listed, obviously, but you can see their generic terms or the generic names. So Forteo and Tymlos, they're almost like household names in spine surgery now. We talk about them all the time when we go to conferences. And when you look at these preclinical studies here on this table on the left from a 2017 review article, it showed that increased fusion in almost every instance. When you start to look at the clinical studies, same thing. You see increased fusion in the teriparatide group. You saw decreased loosening and increased insertional torque. So we know it affects bone density. We've seen that in studies, but it's probably also helping or improving bone quality. And those two together are giving us better outcomes or potentially better outcomes in these patients. So they're widely used now, especially in deformity surgery. It's almost a gold standard. I don't know that I've seen that paper pop up yet to say that you must use this, but I don't know that a lot of deformity surgeons are excited to do or deal with the complications associated with not using this medication. We usually use it before and after, and the optimal timing and results are still being studied. I'll touch briefly on another paper that just came out that I think gives us some guidance on that, but it's still not, there's no definitive answer on when and how you use these medicines. This was a couple other papers that compared these to bisphosphonates, and as you can see, they had a higher fusion rate and decreased screw loosening once again. Another new medicine that is starting to be talked about more is this romosozumab. I don't know if I say it correctly. It's Evenity. It's a very expensive medicine. It's an injection once a month. It's a monoclonal antibody. It actually targets a molecule called sclerostin. And what's interesting is it actually increases both bone mineral density, as we can see on measurements, and it also decreases resorption. So it kind of works in a similar fashion as a bisphosphonate, but it has a higher effect on increasing bone density. So there's actually clinical studies that have shown, not in spine patients, that it decreases fracture risk by 73% over 1 year. And so in patients that can't take these other medicines like Forteo or Tymlos, it's probably a good alternative. I've used it in a couple of my patients, and one of them in particular, she couldn't tolerate Tymlos because she got hypercalcemic. And so we got an endocrinologist to help her out putting on this medicine. And I'll tell you at the time of her surgery, and this is anecdotal, N of one, so don't hold me to this, but the insertional torque of putting in just normal pedicle screws on her case was incredible. Like I would never have guessed she had metabolic bone disease. So I think there's something here, and I'm not sure. It hasn't been studied widely enough, and it's so new that it's going to be difficult to see data for the next couple of years probably. But there's something here with this medicine. I think it's probably going to be an important part of our careers. So this paper, I think you should take note of. I just read it a few weeks ago. It was published at the beginning of this year. I'm sorry, in 2021. And it really is a nice paper that assessed what we should really do in spine patients from the medical standpoint of treating these patients before surgery. Here's a couple high points from it. You know, they basically said anybody who's over 65 needs to be screened before they do an elective procedure. This included all types of spine reconstruction, so not just deformity procedures. You see Dr. Wenke, there's the senior author, and clearly that was a big part of their interest was what do we do in deformity patients. But anyone under 65, and they broke it down between the 40 to 64 and or 50 to 64 and below 50, and they define a couple of risk factors and different categories of them that this panel had a consensus on. And this panel included surgeons and endocrinologists and other clinicians. So those risk factors are nice to read, and they're all the ones you know about already. I mean, medication, smoking, alcoholism, different types of kidney diseases, et cetera. The consensus was use DEXA across the board. That was the highest consensus measurement modality. They said that CT measured Hounsfield units is opportunistic and it could be good, but they didn't have a threshold. So the slides I showed before with all the different numbers, they didn't say that there's any number that you should go off. So that's interesting. They did say that the first line treatment before elective spine surgery should be an anabolic agent. And they recommended 2 months pre-op minimum, 6 months post-op minimum. They said that every patient like this should be treated for a minimum of 8 months with all medical modalities, including vitamin D replenishment, et cetera. But for the anabolic agent in particular, the minimum 2 pre-op and 6 post-op. I've been doing more than that. Again, I don't think there's a consensus. Sometimes it's patient dependent. How bad was their osteoporosis? What kind of surgery are they going to go through? So clearly there's room for more definition here. But this is probably one of the best studies I've seen to try to define this for us. And so from surgical techniques, and I'm just going to blow through these because I'm almost out of time here, because again, I think the surgical techniques, as you go through fellowship, as you go through training, and even through our practices, we're constantly battled by each case is different. And so no one study is going to fit every single situation. But these are just things that people talk about. So cement augmentation, you know that we have fenestrated screws now. You can inject cement before you put screws in. It can increase screw pull-out strength. It might decrease the amount of loosening. It may or may not impact fracture risks. We actually did a study here on that I'm working on publishing now that was a biomechanical study on cadaver bones, and we saw that really it increases the amount of load that is necessary to create a fracture, but fractures still occurred even at physiologic loads. So it does transfer loads to other levels. I think that's important to understand. It's not a guarantee. PJK prevention, boy, you could talk about this for hours. We still do at every meeting I go to. I see sessions on this. I had on there the slide last year, it said age-adjusted alignments, and I took that off this year for Greg so he didn't just chew me out afterwards. But I think it's important as surgeons, we need to have alignment goals. And I think however we're evaluating that, it's going to change over time. I think as long as you're thinking about things like that, you're going to probably help yourself with your PJK rates. Tethering, yes, no. There's more people that keep saying yes, and some people don't use it ever. A lot of techniques in terms of percutaneous fixation that may or may not need it. Again, all could be debated for hours. Vertebroplasty, some people still do it. I still believe it transfers load. I'm not sure it creates a situation where it fixes the problem. And then some people cement augment their top screws, but again, widely debated, still has a lot of room for improvement and definition over time. BMP use, I think if you're doing an open fusion, it's off-label, obviously in the posterior aspect of the spine, but it does increase fusion rates. And in these patients who are having struggle just to create their own bone or maintain their own bone, it might be something you'd consider. If you're doing an anterior interbody, you could use it on label again, will probably increase your fusion rate. But it may or may not be necessary as we keep getting into the world of emerging implant surfaces. And I think that that's something to think about. It may not fit every patient, but it's something you might want to consider to help patients, especially longer fusions, develop a fusion or get a fusion when their bone metabolism is already impaired. Cade subsidence. Greg taught me this, respect these end plates. You got to keep them healthy. And in patients with compromised bone, that's even more important. Large footprint implants, I love them. I think that they work really well. Now, whether you decide to use PEEK or titanium, I think there's, we could talk about that all day probably as well. I think overstuffing the disc space probably puts these end plates at risk or maybe damages them up upon entry. Again, in these patients, you might not get away with that. I think a lot of people say that term, I got away with it or whatever, but in osteoporotic patients, that could be a dangerous situation. Hardware pullout and failure. I'm even challenged this with today. I mean, I love this topic. I pre-treat all my patients. I do all these things I think are the right things to do. I did a case just a couple weeks ago, 2-level ALIF with percutaneous screws, and she already plowed her L5S1 cage because I didn't put iliacs in. And so, it wasn't a crazy correction. It wasn't something just off the, I usually don't put iliacs in for an L3 down, but maybe I will next time. And maybe it's just that patient, that quality just wasn't enough. So she luckily hasn't had a bad problem from it. It's something we're watching closely, but iliac fixation can really be your friend in preventing sacral fractures or something at the distal end of a construct in lumbar cases. Cervical cases, it's pretty important to think about going into the thoracic spine. That distal foundation is critical in these patients. And if you dismiss it, it will bite you. I've seen x-rays and seen people talk about it in conferences. And, here I am telling you, even after I know and think about all this stuff, I just had a case a couple weeks ago where it happened. And, so there's no perfect situation. There's no perfect recommendation, but think about it. And it's important. We know that percutaneous fixation still preserves that tension band in the musculature. I believe in that. I'm a believer in the less trauma to those aspects of the spine that help support it probably are important. I really do believe, though, the apophyseal ring's your friend. And if you have a properly sized implant like an L-lift or an A-lift, it probably gives you more support and it will prevent that subsidence. Post-op care, again, that paper suggests we need to keep those anabolics going if you started it. You probably want to get an endocrinologist involved unless you have one folded into your spine practice or someone like a PA or a nurse practitioner that can manage this for you. Some of these things need to have labs performed over time. After you finish the anabolic regimen, you probably need to transfer them to something else that keeps their bone quality up, like an anti-resorptive. All these patients, just like every patient, needs proper nutrition, but it's really important as people are building their bones. Vitamin C is a cofactor for collagen, and people that have insufficient vitamin C or they're deficient, they're not going to build bone the same way. And that's, again, probably going back to that quality, how the structure of the bone is formed, even when they're on these anabolics. But remember, you should probably keep these people, engaged some way. You got them primed up and ready, or you put them on a medicine for their surgery, but that's not where it ends. These people are still at risk for fragility fracture the rest of their life. And that could be their hip or their wrist or their proximal humerus. So, doing something to get them checked into a PCP or an endocrinologist that's going to manage this long-term is really important. Again, I didn't want to get in too much to the surgical stuff. I hope some of the imaging and the thresholds and the other methods, at least giving some guidance, was helpful. Top left picture, there's my team. One of the reps there, he's moved on, but the other guys are my invasive guys, and one's a Globus rep. And then on the left, the three women, those are the people that work with me in the OR. They're just the best. We try to do things. I learned from the best here. Greg taught us about the value of people and the value of your team. And so I try to take them out for drinks or something fun outside every once in a while. Right there on the right's my wife. And then the bottom left, this is an open invitation. I did this last year. If you want to come to Kansas City, say hi, watch a case. Don't even do that. Just meet somebody different across the country. I'll take you to a KU game if it's the right time of the season. Obviously, it's March Madness, so this is a little bit better timing than the last time I did this talk, which was I think in June. But going to Allen Fieldhouse is probably a bucket list thing I would recommend to anybody. It's one of the coolest places to see any sporting event. So with that, I'll stop. And if anybody has some questions or Greg can rip me apart for what I didn't cover, I'll let you guys have at it.
I'm glad you think so highly. I'm not gonna rip you apart. That was a great talk, Brandon. That was absolutely awesome. Super insightful, and I think really helpful for the guys on the call. I think it's part of our practice. Seeing more often. Can you just give me? Don't make one of the little questions I have for you is like, when do you start like the vitamin D calcium supplementation thing? And then at what dosages do you use?
Yeah, great question. So in any patient that walks in my clinic, tomorrow I'll have clinic, I guarantee I'll see one, maybe two. They're choosing now to go for an elective surgery, and I'll, if they have risk factors or in their age category, we'll just get baseline labs and I'll get a DEXA. If I haven't had a DEXA in a year, I get a DEXA. If their baseline labs show an abnormally elevated PTH, and let's say their DEXA is osteopenic or osteoporotic, one of the two, you need to correct their vitamin D most likely elevated PTH and their vitamin D is low. So that PTH is a response, it's a feedback loop. And so we get them on pretty high dose vitamin D right away. So we'll do 50,000 units 3 times a week for 6 weeks and recheck their labs. If their PTH is still elevated after correcting their vitamin D, they need to go see an endocrinologist because they probably have hyperparathyroidism. And we've diagnosed that in my clinic probably 5 times. And then they go get their parathyroids removed and their labs correct. And then you you move on. But that was the etiology of that person's low bone density. Now, if their PTH is artificially elevated because their vitamin D is low, we do the 50,000 3 times a week for 6 weeks. And that regimen came from a conference my nurse practitioner went to, which was just an osteoporosis management conference. That's pretty simple. She goes once a year. And then we stop and we go down to a maintenance dose. That one's more like, licking your thumb and kind of looking up. There's literature in the breast cancer population that 5,000 a day it probably is advantageous for helping your immune system and fending off cancers and things like that, which, again, I'm not trying to get into a stretch here, but there's a guy out of Omaha that I think he was at Creighton, if I'm almost positive, that they did some pretty interesting prospective studies where they put people on really high doses, like 10,000 units a day for 2 years, and they saw no toxicity in adults. So I think if you pick something like 1,000 or 2,000 a day, or if somebody takes 10,000 3 times a week or 5,000 a day, all of those are probably safe regimens. I would just say that if you're going to be the one taking on that recommendation at some point along the way, 6 months later, a year later, recheck it. Because people that are chronically elevated for years on end, maybe their vitamin D levels now into the 120s. There's some endocrinologists that kind of get cautious with that. And maybe it's nothing, but maybe it's something. So certainly we don't want people to get low, and we all get low in the winters when we're inside and we're not exposed to sunlight. But if you put them on a high dose, you probably want to be able to have the capacity or the wherewithal to go recheck that later and maybe adjust. My current regimen is 2,000 to 5,000 a day. It's like dealer's choice, because when people go to the pharmacy, there's 2,000 unit capsules and there's 5,000 unit capsules. I just said, find one of the bottles that works for you and just take one a day. I don't know if that was helpful or not.
Yeah, that was totally helpful. Thank you.
Any other questions?
One question. Hey, how you doing? Dave Glassman. I do spine down here at the Navy Hospital in San Diego.
Yeah.
When you're trying to look at these bone densities, and this doesn't happen, too often, but full length Scoli instrumentation and then like bilateral total hip arthroplasties, are you doing any wrist DEXAs, or do you find that the CT scans are beneficial enough to try to read Hounslow units, or do you just presume that if they're over 65, they probably have bad bone and go with that?
Great question. I do wrists. I do them in exactly the scenario that you said, when I can't get a femoral neck. It's interesting. Like, I've just tracking my own kind of patients and situations. And the one you just mentioned is the challenging one, where they've got instrumentation, maybe T10 down or L2 down. All the recommendations for where we measure are down in the low lumbar region. So it's difficult. And then you can't really measure around a screw, get the streak artifact. It's artificially elevated. I would not recommend that. I've never seen somebody say that that's a good option. I think that in a patient like that, for me at least, if they were L2 to pelvis already, or maybe 10 to pelvis already and needing an extension, I will assume the worst. And I think that's probably safer than thinking, well, I can't measure anywhere, or the wrist was mild to moderate, I'm just going to say it's all right. So I will probably, unless they've already been pre-treated, which is another challenging situation we're all running into now, is if someone's already exhausted their Forteo or Tymlos 2-year regimen, what do we do now? And so I think in a 10 to pelvis needing an extension above, my practice currently is I'm assuming that they have metabolic bone disease to some extent, a little bit biased because of my paper, that 67% of people have something wrong, and we're not able to really quantify their quality. So I go ahead and treat them anyway if they can be treated, because I just think that the risks or the fallout of not treating is so high in some of those patients.
Really appreciate it. Thanks for your thoughts.
Yeah. The wrist DEXA, though, is still accepted, I guess. I think it's useful. It's not like it's, junk data. I really like a big degenerative scoliosis in a non-instrumented patient. That lumbar DEXA is not worth your time. I tell my residents, don't even look at it, because they'll report it in our pre-op conference or something. I said, no, that's not the one you want. And so I've tried to figure out how to order just the hips, and they won't do it. It's like a billing thing or something. They want both of them so the radiologist can read them both. But I still think there's utility in that wrist. And I think if you get a number that's concerning, now you got great objective data to go ahead and proceed with this information or proceed with this type of treatment. The only other thing I'll add to that is you're going to need something potentially to get these medicines approved. And if the only thing you can get is a wrist DEXA, then I would do it. And it's not wasting time. And I think it might help you get an approval. We have some patients that can't get approved at all. And we have a good relationship with some of these companies that they'll give samples and they'll follow these patients. So that's the only other thing I'd say about the wrist DEXA is you might need it. It might be helpful for an insurance approval.
Great point.
Yeah, we get it quite
Thank you.
Especially in those that have had previous, hip replacements, because I don't ever trust the lumbar spine for the purposes of diagnosis and management as it relates to if I'm worried about them. So if they have bilateral hips, I always get the wrist.
That high resolution.
Guys, we're a little bit over. Thank you all for coming on. Brandon, thanks for logging on. You guys feel free to hang out. I do need to go check my patient for surgery. So great seeing you, man. And look forward to catching up soon.
Absolutely. Thanks so much, everyone.